So I'm going to talk about how viral sequencing during the pandemic really contributed to our response, and that's why I called it Celebrating the Contribution of Viral Sequencing. Now, we live in a wonderful city where sequencing, certainly the genetic code was first understood, and where sequencing really began to take off with Fred Sanger, and then with sequencing instruments that could do sequencing very rapidly and effectively. But it actually is a really quite a short story from the time that you could sequence a genome of either a human or a pathogen to now. So if you look at this figure here, nope, that's not what I wanted to do. I wanted that one. Yeah. So here, 2 decades ago, it would cost around £500,000 to sequence a single bacterial genome. They're quite small. And so 18 months, full-time, huge team doing that. And that was just 2 decades ago. And that was really located in specialist centres like the Wellcome Sanger Institute, which is what you see there. Now, by a decade ago, actually that technology had really changed. It would cost £50 to £200 to sequence one pathogen genome. And you could do that in hours or days. And you could actually do it in the kind of laboratory that I've shown here in this photograph, which is where I've worked in Cambridge in the microbiology lab. So this decade, in the pandemic, the cost of sequencing hadn't really come down and the timeline hadn't. But what we started to do with the pandemic was really network together to great effect for public health benefit. So when the pandemic came along in 2019, I'd been working in sequencing for around a decade, and we were really on the starting blocks to use this in earnest. We'd never used this prospectively during a public health crisis in the past, except for in very much sort of research context of, for example, trying to piece together Ebola spread. But the sequencing cost had plummeted. It was quick and easy to do. And so we were looking for applications for this technology. And then, you know the rest, SARS-CoV-2 emerged. Now, I just want to describe the way I see the virus, really. So when it first emerged, it was a fit virus. What I mean by that is it had an R0, this basic reproductive number of around 3, which means if I've got COVID, I'll give it to 3 people. And each of those will give it to 3 people. And so the numbers of people with COVID start to exponentially increase. It was also fit and actually caught us on the hop somewhat, in that virus shedding started before we got symptoms, and a proportion of infected people had no symptoms at all. So we could be mixing together until lockdown, and you might not necessarily know who was infecting whom. So this was a fit virus. So why on earth did we need to sequence it then? Well, the reason is because of natural selection. That allows fitter variants to emerge from the original virus that was first detected in Wuhan. Now, what do I mean by natural selection? Well, this goes back to the work of Charles Darwin, who did a lifelong study of the natural world. And he published a joint paper together with Alfred Wallace, talking about natural selection. He went on a year later to publish On the Origin of Species. And a good demonstration of natural selection was in his description of Darwin's finches during his travel. What he did was he studied the beaks of finches and noticed that they were quite variable. And he described that individual organisms, for example, birds of a given species, they show a wide range of variation for a given characteristic, such as a beak. But individuals with characteristics most suited to the environment in which they find themselves are more likely to survive and breed successfully. And that characteristic then passes on to individuals who survive and pass it on to the next generation. So what did this mean for SARS-CoV-2 evolution and the pandemic? Well, to tell you the truth, when the pandemic emerged, scientists were very unsure about what it would mean. So these are some of the comments I heard. So the virus won't change that fast. So lots of sequencing will mean detecting the same variant over and over again. Some people said we don't know the timescale for genetic change, which is true actually. but it would pay to be prepared. That's my kind of version of events. It certainly pays to be prepared. Some people were talking about the cost of sequencing. So weighing up the individual and collective appetite for risk, spending taxpayers' money. The money I got from the government was actually, taxpayers' money, and also professional credibility. And so to stand up and say, we're going to do this, we don't know if we need it yet, actually you're taking a professional risk because actually you might not need it, but you think you do, but you've got nothing else to base your view on. So we did start to sequence the virus, and I just want to talk through why. So this is at the top a schematic of the SARS-CoV-2 genome. And what you'll see here is this gene here, which encodes the spike protein, which is decorating the outside of this virus. That's why it's called a coronavirus, because it's like a kind of a crown of spikes on the outside. Now, the spike is really critical because that's the thing that locks on to our host receptors in our cells and triggers uptake. And viruses can't survive outside of the body, so they get into the cell, and that's where they start to replicate. And that's the thing that our immune system is targeted against. And that's what was so important to vaccine development, but also the thing that we tracked very closely when we were sequencing. So what happens when mutation occurs? Well, the rate of mutation was around 2 mutations a month during the replication of a virus from person to person, which doesn't sound very much, but when you think of the many millions of people who were infected, that's actually a lot of mutation. So a mutation leads to one of 3 outcomes: either no effect and no apparent change, so it doesn't really matter if there's a mutation because that mutation doesn't then affect a protein that it encodes for and the behavior of the virus. It can lead to a disadvantage of the virus, in which case you're not going to see those or they quickly disappear out of the population. The ones we really worried about were those that created an advantage to the virus, potentially natural selection with lineage expansion, because these viruses could outcompete the other viruses that are circulating at the time, other SARS-CoV-2 viruses. So this is what I'm going to really focus on, things that give it a fitness advantage. So ABC of variant assessment really for us was, do we see a virus emerging that's either more transmissible, escapes the immune system either from natural infection or from vaccination, or does it cause more severe disease or less severe disease actually? And any given virus could have a combination of these, and this is what we really were focusing on. Now, you would have heard about the escalation and classification of variants on the news, but we were really doing sequencing and horizon scanning for anything that really looked unusual. Now, you don't see that in the genome, really. It's like trying to pull a needle out of a haystack. You're looking for a variant that is causing a different characteristic in its population, i.e. transmitting more quickly, as the alpha variant did in Kent, or appearing to evade the immune system. If something comes up on the register, then that becomes a variant of interest until you can really pin down whether it's a variant of concern, which is increased transmissibility, increase or change in virulence, or decrease in effective public health measures such as vaccination. There is a 4th characteristic which called variant of high consequence or classification. Fortunately, we didn't ever see that, and that would be a virus that had mutated to become highly lethal, or where vaccination wasn't effective. So this is probably the image my favorite slide of all time. And what this shows is variants over time in the United Kingdom. Now, what you'll see on this axis here, I can, I just have to work out how that works. Yeah, so that starts around the time that that we went into first lockdown, March 2020, and it goes through to July 2021. Now, this is normalized. So at any given point, any virus that is circulating, this is normalized to 100%. And what you'll see is each color is a different variant. That means it's got one or more mutations different from the Wuhan variant, the various virus that first appeared. So in wave 1, there was a cacophony of different variants all circulating, and none were particularly outcompeting the rest. In wave 2, there's this red kind of mound here, B1177, and we thought that might start to be looking interesting but actually we subsequently refer to that as the summer holiday variant because actually this was occurring because people were going overseas and acquiring the virus, coming back, and then actually spreading it. It was first detected in Europe. So this was actually a big expansion because of transmission as a result of holidays. But then you see alpha variants start to appear around mid-November into December. And this is what you'd call a sweep. So everything is replaced that was there before. And then, of course, Delta then swept away Alpha. So you saw these waves of variants actually coming in to the UK and elsewhere, ending in Omicron. Now, this is a really interesting graph because it actually puts all of what I've said into perspective. So on the y-axis, you've got the relative fold increase in fitness over the original Wuhan lineage. So if you have a relative fitness of 1, that means you're the same fitness as Wuhan, and then it goes up to 9, which means that you're 9 times fitter than the Wuhan lineage. The size of the dot is the number of isolates that were sequenced. And what you'll see is that actually the variant right up at the top right-hand corner here is actually the Omicron variant that's circulating. So you can see the incredible journey that this virus has had during its process of natural selection and evolution over quite a short time frame. Just to see the estimates of transmissibility that these viruses have, and much of the fitness is down to being able to transmit more readily between person to person. You'll see here that this is estimates of transmissibility for wild type, which is Wuhan at the bottom, and Omicron at the top. And this just really is a reflection of that previous graph. The Omicron was much more transmissible. So if you have Omicron, you're going to give that to between 8 and 9 people who you meet, and so on and so forth. So transmissibility underpins the fitness advantage of these variants. Now, also, if you're looking at estimates of disease severity, you can have a kind of relative risk on crude data, and that's shown here in these bars here. So probability of hospitalization given infection, probability of death given hospitalization, and probability of death given infection. And what you'll see here, just in kind of absolute terms, is that Delta and Alpha were sort of fairly high up. So here's Alpha, and more likely to die given hospitalization, and more likely sort of probability of death given infection. But actually further on in the graphs, what you'll see here is what is ameliorated by the impact of vaccine and infection-induced protection, so that towards the end, the risk of dying was much reduced because we'd all been, well, many of us had been vaccinated or had had the infection ourselves. Sequencing also underpins our understanding of relative immunity to infection. So sequencing, if you like, is a kind of putting isolates into buckets. So a bucket of alpha variant versus delta variant, or a pre-alpha versus alpha. So what this study shows here, and it's a very early study in the pandemic, was that some COVID-19 vaccine recipients who'd had 1 or 2 doses of the Pfizer vaccine or Moderna vaccine, they obviously had immunity in their bloodstream, their antibodies. Now, if you mix the virus with their blood, the antibodies will coat the virus and will no longer, that virus will no longer be able to actually be taken up into cells effectively. So it's a neutralization assay. And so what this has shown is that over time, quite quickly, we saw a fall off of neutralization as more and more variants arose. And this is an old terminology here, but it just shows the point that sequencing was really central to this. I would say that also genomes inform vaccine design. So the very first genome was not published in the UK, it was published in China. Eddie Holmes, who was working in Australia, was instrumental in helping the Chinese to release this genome. They had got the isolate from somebody who was admitted to hospital towards the end of December 2019 with symptoms that were consistent with COVID-19. And this led directly to rapid vaccine development. Without that, it would have been a much slower process. So we know that 2 vaccines came along, but a lot of that was on the back of a vaccine to the spike protein. Actually, sequencing also informed vaccine redesign. So here we have a kind of a model, if you like, of the spike protein from the Omicron virus versus the original Wuhan strain. And what you'll see here is all of the different mutations here. There are many of them, 50 or so, on the spike protein. And that was used by developers such as Moderna to re-engineer their vaccine. There were other benefits flowing from sequence data. For example, it provided evidence-based insights into outbreaks in hospitals, schools, prisons, etc. And it also helped us to think about travel. Now, there's a lot of debate and discussion about whether we should close our borders or keep them open, whether closing our borders was an effective restriction. I think I'm going to show you 2 brief vignettes to help demonstrate why sequencing really opened our eyes. So, if you go back to March 2020, where we closed our borders to China, for example, and we closed our borders to other countries, what we did around this time is we sequenced viral genomes. So you'll see here, we sequenced SARS-CoV-2 genomes in June 2020 in a database, and we had 50,000 genomes. What we then did was we looked at the likely origin of the viruses based on their genetic relatedness. So you can see here that there's a peak here in March. This is our kind of first wave, if you like, in England, Scotland, Wales, and Northern Ireland. We then worked out where they had originated from. And although we sequenced only around 10% of all virus infections that were diagnosed at that point, we found that there were more than 1,000 identifiable independent transmissions to the end of April 2020. And what was actually really surprising was that actually there were very few introductions from Southeast Asia. 1/3 were from Spain, about 1/3 from France, and 12% from Italy. So actually this was a European pandemic raging around Europe. And so our border closure with China, actually, we'd already missed the boat because actually most of our disease was being imported from Europe by this stage. We also attempted to think about border closures with India and Southern Africa later in the pandemic. But this study traced the introduction of Omicron into England using over 100,000 genomes. It found that there were many thousands of introductions into England, and then looked at whether it was importation and the timing of the importation in relation to shutting borders. And at the bottom line is the importation of Omicron continued despite subsequent restrictions on travel from Southern Africa through export from well-connected secondary locations. And so on the whole, this was, and by the time the borders were shut, we were already transmitting Omicron across our country. So travel restrictions were very limited, if not useful. So the second half of my talk is really, we were leaders, one of the leaders in the world in sequencing, and I just want to actually raise a few points about how we succeeded. People have said, how did we do it? And I've actually got 8 illustrative points that help you understand how we succeeded in embedding this technology during a national emergency. The first is the past prepared us for the future. So we've had excellent science funding in the area of genomics. We have very strong UK research engagement over many decades, and those deep roots were really important in being able to get sequencing off the ground as quickly as we did. It was the same for vaccine development. It was the same for clinical trials. We couldn't have done that from scratch. It's because in this country we have a legacy from excellent science funding and excellent scientists. The second is that actually we did have real world practice. So people had been experiencing sequencing of MERS, Ebola, and Zika. And so there was an understanding of how to do this in practice. The third, around science investment, we had a cloud infrastructure for microbial bioinformatics just sitting there waiting to be used. We had a network for methods development for sequencing, Arctic, and we had major investments in the Sanger. So this is what I called readiness versus preparedness. So that means we hadn't spent many years stockpiling equipment, stockpiling reagents, thinking that this was coming down the track. That's what I'd call preparedness. But what we were was ready. So we could do this if called upon. The second was we acted at pace, and we were funded at pace. So this is a timeline of March 2020. This you see the dates in March. Now the top is the number of diagnosed cases in the UK, which we know was a gross underestimate because we didn't have enough testing. And the bottom is our sequencing. So I'd already spoken to Sir Patrick Vallance, our Government Chief Science Advisor, and Chris Whitty, our CMO, about the need for developing sequencing of the virus. And so I was tasked with going to set this up. I didn't quite know how to go about this, but I knew I needed to get people to help me. So the first thing I did on the 4th of March was pick up the phone to 5 of my colleagues to say, do you think we need to do this? And are you with me on this? And I got full support from them. I then circulated an email to get 20 people together to work out how we were going to do this, the where, the what, and the how. We had a first meeting in the Wellcome Trust in London on the 11th. That's the last face-to-face meeting we had. We had that meeting on a Friday, and over the weekend we wrote a proposal to give to Patrick and to Chris. And on the back of that, they gave us around £13 million to get going. But we didn't wait for the green light. We didn't get the green light on that money until the end of April. And so we got sequencing underway at risk to ourselves. The financial budgets that we had available, we started to do this in all seriousness and started to get teams together who could do all of the things they needed to do around analysis, report writing, methodological development. So by the 23rd of March, our first report was sent to SAGE on the sequence data that we'd developed. And at the same time, we extended the cloud infrastructure to take viral genomes. So we began on the 1st of April. What we did was we developed something called COG-UK. So COVID-19 Genomics UK consortium. It had 21 partners in the first instance, that more came online, but there were 16 regional sequencing sites across the country. We had the Wellcome Sanger Institute as our big high throughput hub. The entirety was actually administered from the University of Cambridge, and so the project was managed there. And we had the 4 public health agencies working together. The first time they'd worked together in this way for sequencing or other factors. And I think another point apart from speed was teamwork. So we had one team focused on outcomes over process. There were 600 people in the consortium, nearly all of them volunteers. And so we simply thought about how we get this over the line. We had a consortium agreement and a data sharing agreement signed by the public health agencies and the academic institutions. And our sequencing network was looking something like this. So every dot on the map is a laboratory that's testing patient samples. This is for hospital laboratories. And the color of the dot is where those samples were sent for sequencing. So if you look down in, for example, down in the West Country, you'll see that many of these are going to Exeter, for example. And if we go up to Liverpool, you can just see how there's a cluster. Am I in the right geography there? There. No, there, there. Yes, there. No, it's there, isn't it? Yeah. Lower. Okay, let me get this right. It's here, right? Is that it, right? Great. You can see that geography is one of my strong points. So we had this network, and we had to start from scratch, actually, to get samples from these labs into the sequencing facilities. And there were extreme examples where actually people would be driving out to pick up samples themselves until we got this really working. Now, if you're in the community and you got tested by Pillar 2 labs, for example, these are called Lighthouse labs, they all went down to Wellcome Sanger Institute for sequencing. And the Sanger, they refer to themselves as the waste disposal unit for these Lighthouse labs, because basically the tests were done in 96 well plates, which may only have 1 or 2 positives in them. And they were all shipped to a freezer in their kind of car park And when they were ready, they would just like cherry pick out the positives, and then the rest would need to be disposed of. My fourth point is we were willing to work in an imperfect system. So scientists don't feel very comfortable about this. They want to study, evaluate, perfect, get it peer reviewed, and then think about it again. Actually, this is a cartoon from Sam Robson, who was in the consortium, and it really was like flying a plane while still assembling the pieces. So there was always something changing in the system. A new lighthouse lab would open, and we'd need to try and get those samples. There was huge flux in the system, and that felt pretty uncomfortable for somebody who likes to have things, nailed down before you then write your nice paper and get it published. I think the fifth was that many things were centralized during the pandemic response. Actually, as the director of this consortium, I decided to devolve everything out for sequencing, but also the entrepreneurial side of things. So who could ever do the method development, the linkage of data to the sequence data and the patient data, whoever could do the analysis tool development, much of which was done in Edinburgh, people did that, and we'd gather once a week to find out how we were progressing. But there was important devolution. And I think during the course of the pandemic, we saw how important it was to devolve responsibilities, for example, to the metro mayors and other big cities. My sixth point is we shared everything to increase our impact. So everything we generated has been shared worldwide. Our methods, the way we referred to the variants, and all of the bioinformatic tools were all made available. All of our data was released as soon as we could make it available to people in various different databases, which was open to the public. As we progressed and matured, and there was a greater capacity elsewhere to do sequencing, we started to wind down. But we wanted to know how good were we, where were our flaws? And so we asked around Europe to evaluate how well we'd done and how we could have done better. And so that publication is in the public domain now. And it's around sort of, 80-page document, or perhaps longer, which details what we did, how we did it. Finally, I think people are at the heart of this. We shared the dividend. So this is the 600 people in the consortium. If anybody wanted to publish with our genomes, the insistence was that you have the COG-UK name on that paper, and then together there would be a list of people in an appendix saying who contributed. The technicians, the people doing the sequencing, the people taking the samples. People were at the very heart of this, and so they shared the publication dividend. Now I'm going to finish by saying that over time, it became really clear to me that actually there were very few women in my consortium at a leadership level. So I had a steering group and I had an advisory group, and I realized that actually many of those were men. I think, as many people do in times of emergency, I reached out to the people that I thought could help me quickly, and the people that actually put up their hand and came forward, many of those were my male colleagues. And so we ran a program called Women in COG, People Who Changed Our World. And we have a series of interviews, including with June Rain, for example, who is the director of MHRA. And that was, and people who supported us very much included Jeremy Farr. You can see his picture there from the welcome. But I felt that we needed to really talk about women in the workplace and the fact that they had contributed so much. And we did see many women scientists standing up and advising. And we've turned that into a book, Snapshots of Women in COG-UK. So thank you for listening on that whistle-stop tour, and I'm happy to take any questions. Thank you.
That was wonderful. It sounds so easy the way you presented it.
That's the retrospectoscope for you. At the time, it wasn't easy.
I'm sure there'll be lots of questions. Looking for a hand to go up. But let me start while everyone else works out what the question is. Lessons learned. Are we sort of ready next time?
We're ready for the genome sequencing. It has all been deconstructed now, so there isn't a COG-UK. So we'd be ready because we have the same level of incredible scientific expertise in this country. People know how to do the sequencing, they've got the sequencing instruments, none of that has to be bought. We have the reagents and so on, and that's what really allowed us to start. We were simply ready to do it, and we could do it tomorrow. We could turn on the tap. The tap's been turned off, but for other things, I think, in terms of other things, I think.
Because we were way behind on capacity to test, and
yes.
we did have a shortage of PPE.
Yes.
It's probably a sideshow, but the testing capabilities seem to be a bit of a worry.
Yes, and my sense is that and the other thing that I thought was extremely good in this country, there are many good things actually, but the COVID-19 survey that was set up by the Office for National Statistics. So that went out into the community, testing people over time to see how many people in the community, some of whom may not have a test, would actually was positive, and that allowed us to get national data. That was also deconstructed, and so we know how to do it, but I think that it's potentially short-sighted that we have now actually deconstructed our testing capability as well. So are we ready for the next time? Well, we'll have more knowledge, but I worry that other things are distracting our attention at the moment from the next pandemic. In many ways, that many people are worried about what's happening in the world. But I think we've taken our eye off the ball in terms of the pandemic.
The question.
Your remarkable group's work is utterly fantastic, and we're all full of gratitude for it. You mentioned, are we ready for the next disease X or whatever it's called? An interesting case study, which hasn't really been explored very much, is what happened in sort of September, October, November of 2020, when, I mean, most people feel that that's when B117, now called Alpha, started to explode. The epicenter seems to have been on the Isle of Sheppey initially. It may well not have originated there, but that's, and it became, I was watching the numbers and they were growing faster than anything, while the Northwestern and Midlands outbreak, I think you call that the summer variant, was starting to die down. And SAGE was starting to say, things are getting better. We're quite hopeful of the future. In fact, SAGE didn't even know about B117 until the minutes show in early December, when all of a sudden panic set in and the government started to react. So it's about response time. I mean, we know that B117 was first sequenced by Sanger in late September, but it really wasn't until December when we started to deal with it. Now, the virus can move much faster than we could then. Are we any better now?
Yeah. Well, before I say are we better now, I would say several things. First of all, the virus that emerged, Alpha, was really quite unusual in that it probably developed. It was in somebody who couldn't clear their infection, most likely, and this virus evolved within the human body, and actually it was like a kind of evolutionary gym. It could actually work out which, through natural selection, I guess, within one person, how it could actually survive in that individual. And so it had many mutations. Alpha had many mutations compared with Wuhan. So it's very likely that it emerged from somebody who, because it had a huge genetic sort of jump. Should we have spotted it earlier? Well, I think that there's a couple of things to say. The retrospectoscope is a great thing. It would take us at that time around 2 to 3 weeks to get the virus, extract the information, do the sequencing, put the data together with the patient data, and then hand it back to the public health agencies, who would then actually do the critical step, which is to connect it with the patient data. So we generated this information for public health agencies, and that had to then be linked. There was a firewall. They would link that to the public health information. So that's that. This doesn't happen overnight. We can't sequence in an hour and then get the data back. It had to be linked. So we got quicker with sequencing over time, but certainly in the first few months, it was taking sort of perhaps 3 weeks or so. So that's one delay. The second delay is that, as I say, you really need to connect it to the patients, and you need to see what's happening with the rate of transmissibility, for example, and that takes, careful study. I think that the third thing is that actually spotting a variant, you saw that picture with the wild colours, spotting the first variant. If you looked at the kind of bulge of the red bulge, the summer holiday variant, 30% of the population actually had that variant at any given time. So you're right to say that the first variant was sequenced in September 2020, but there was no reason to think that that was any different to any other virus, actually. It had quite a few mutations, but actually it was one of about 300 variants circulating at that time. So even when it was at 5% of the population, that's still within the range of noise. So when you add that together, it was really only when the virus started to spread between people clearly more quickly that it then became obvious that there was something there. I think people think we kind of somehow can spot from the genome what something is going to do. That just over time we got better at doing that because we know which mutations were associated with greater transmissibility. Leading up to alpha, we didn't have any of that information in our back pocket. And so I would say that it was, as the first variant, it was actually pretty tough to spot something that was going to run away with you. So yeah, that's what I would say. So I think it's easy to look back. At the time, it wasn't as easy to spot actually what was literally a needle in a haystack. And in fact, because there was quite a lot of discussion around alpha variant and how we detected it, we wrote quite a long piece about exactly what the numbers were, what we saw, when we saw it, etc. And to explain that to people, because I think there's an easy misperception otherwise that that we were sitting on our hands, waiting, and not doing enough.
Mike.
Thank you so much. Very, very, very clear. Just with hindsight, is that all right like that? Yes.
Yeah.
Do you think that the British lockdown was effective or necessary or not comprehensive enough? What's your judgment looking back?
What I would say is that the first lockdown was essential because we had no other tools in the toolbox. We didn't have vaccination. Vaccines weren't. The first vaccine was injected on the 8th of December 2020. And I think that that we had a population that was largely unimmune. Every one of us had the potential to have COVID-19. So there weren't many tools in the toolbox, and I think that locking down was important. Now you could say you could stratify that so that you actually protected people who were immunocompromised and needed to be shielded. But I think that in March 2020, I think we were in a tight spot. We could see what was happening in Italy, which was very drastic, and that was what was available to us. I think that, again, is this kind of hindsight knowledge where could we have finessed it more? I think if we had the information we have now, then maybe we could have done. But at the time, I think that the SAGE was actually making decisions on very little data, actually. So I do believe that certainly the first lockdown was the right thing to do.
Thank you very much for your presentation. I've read the national risk assessment with the national risks which go from pandemics to solar flares. That document was produced in advance. Did that help you, or did that help the response at all, or was everything thrown out of the window? And also, with your sequencing, you did so many genomes and so many sequences at an incredible rate and speed for feedback, which I think was only exceeded by perhaps the Netherlands, I think. But throughout the world, there was a lot of lack of sequencing in some other places. What could other countries learn? Thank you.
I'll answer the second question first. We were quick off the mark. There were several, as you mentioned, other countries, I think Denmark, Netherlands, several other countries were also quick off the mark. Actually, often down to academic groupings coming together. Other countries, it was quite interesting, but for various reasons, didn't seem to be able to assemble their sequencing capability as quickly. Partly because their health system was fragmented. So, for example, or geographically distinct. So, in the US, for example, we know the states are very large, and often operate independently. So that was very difficult to link the national data up. So, but I think the thing that really bothered me most about lack of sequencing was those countries where there was no sequencing capacity. So we actually set up a group called COG-Train, which provided free online training in how to do sequencing from start to finish, interpretation, etc. And that ran through five free online courses. But that sort of troubled me greatly because you haven't got the capacity overseas, even though many countries, you couldn't guess where a new variant was going to operate. It was only fair that that country had access to understand what was circulating in their population. So we decided to really invest in training because we weren't in a position to send lots of sequencing machines overseas or reagents and so on. So I think there's, and the inequity of the pandemic was also seen with the vaccine distribution, for example. So there was a lot of inequity peppered throughout the COVID response. The first was the risk register. Your question about the risk register, did it help us? Well, I don't think anybody thought to put sequencing in the risk register in terms of the response. The pandemic response that had been rehearsed by the government was actually based on pandemic flu. And in relation to sequencing, that was sequenced, but retrospectively, so the last outbreak of flu, sequencing retrospectively to better understand the disease. So nobody used sequencing in this kind of semi-prospective, sort of reacting to a problem. So we were working on the basis initially of pandemic flu rather than coronavirus, which wasn't the best. But I don't think anyone's put the word sequencing and risk register together before, so that's quite a novel juxtaposition.
Very much, a very interesting talk. This may sound like a very naive question, but how important is the interrelationship between immunization and variant development?
I would say that they are inextricably linked in many ways, because if you look at natural selection, a variant would need to circumvent the immune response in order to transmit, persist, and survive. And so a variant that is able to circumvent the immune system, whether it's through natural infection or vaccination, will be one that actually has an ability to do so. And so it'll try and skirt around the immune system. So the two are absolutely linked. So if a virus is going to be selected that's fitter, it's got to transmit, but it's also got to infect people who have an increasing proportion of immune protection from the original virus. So it's a very important question you've asked.
And is this being looked at now? I mean, is there ongoing analysis or data analysis on populations where there's a high level of vaccination to give some type of immunity and the development of new variants?
A lot of work was done throughout the pandemic and continues, looking at the immune profile of the various variants as they've emerged. Interestingly, immunologically, what you'll find is that initially the immune landscape of the different variants actually were kind of quite different. So they were finding different ways of escaping the immune system. But what the virus appears to have done now is backed itself into a kind of ecological corner. So all of the new variants are offsprings of Omicron. So initially they were quite genetically varied, but now it's daughters or offspring of Omicron. But there is work ongoing actually in immunology. I think that you need that, otherwise you don't know how well protected people are from the vaccines that we're using at the moment.
Thank you.
I'm sure we could generate lots of questions. I've got lots of minors, but I think maybe this is a natural point to thank Sharon very much for
Thank you.
just a wonderful talk. It's been a wonderful evening, and there is an opportunity to carry on chatting afterwards. But thank you very much.
Thank you. Thank you.